Given the devastating effects of depression on an individual and the collateral damage to those around them, researchers continue to explore effective treatment options and develop new methods based on evolving understanding of the underlying causal mechanisms. Our understanding of what causes depression, or any psychological disorder for that matter, drives the treatment. Currently, the most widely used treatment approach is the use of antidepressant drugs. Use of these drugs is based on the assumption that there is a disruption in the normal communication process between neurons, and that artificially increasing or decreasing levels of certain neurotransmitters through the introduction of drugs can rectify this imbalance. Antidepressant drugs can work through a number of different processes. After a neurotransmitter has activated the postsynaptic receptors, it's released back into the synapse. Some of these neurotransmitters are taken back into the presynaptic terminal button and repackaged for subsequent release. Tricyclics are a group of drugs that block this reuptake process, leaving more of the neurotransmitter available in the synapse to reactivate the postsynaptic receptors. After reuptake, some neurotransmitters are broken down into their building blocks. MAOIs work by preventing the breakdown of certain neurotransmitters and thereby increase their availability. Selective serotonin reuptake inhibitors, or SSRIs, are probably the most commonly used antidepressant drugs and include brand names like Paxil, Prozac, and Zoloft. These work in a similar way to the traditional tricyclics, but they only block the reuptake of serotonin. In other words, they selectively inhibit the reuptake of serotonin. As a result, more serotonin is available. Newer atypical antidepressants work selectively on different neurotransmitters. Wellbutrin, for example, inhibits the reuptake of dopamine rather than serotonin. But psychopharmacological treatment is not an exact science. Each of these drugs has side effects. MAOIs can increase blood pressure when taken with certain foods, for example, and SSRIs can reduce sexual drive and cause nausea and insomnia. From the wide range of approaches, you can see that we're a long way from fully understanding the biochemical causes of depression. To a large extent, we're just tinkering and trying to find out what has the most beneficial therapeutic effects while having an acceptable level of side effects. The marketing and sale of pharmaceuticals to treat psychological disorders is big business. But note that the same drug is often promoted as treating very different conditions. An ad for Zoloft promotes it as a powerful treatment for depression and even informs potential patients how depression is caused and how the drug works to address that cause. An almost identical ad shows how social anxiety can be treated by Zoloft. Two very different conditions, but apparently being driven by the same underlying lack of available serotonin and therefore treated by the same drug. How do such different conditions have the same cause? And what about the story of Sarafem, a drug introduced by the pharmaceutical company Eli Lilly to treat premenstrual dysphoric disorder, or PMDD? The drug would allow women to feel more like the women you are, to help relieve premenstrual monthly moodiness. This was a new disorder, a distinctive medical disorder, and with it came a new drug. But this was not a new drug. It was the SSRI Prozac. Same dosage, but changed in color from green to girly pink, rebranded and repackaged. Perhaps this was done with the women's best interests in mind. Sarafem would be less stigmatizing than Prozac. But I doubt it was all altruistic. Eli Lilly's patent on Prozac was about to expire, allowing generic drugs to replace their exclusive hold on the market. By creating a new drug that treated a new condition, Eli Lilly could generate a new patent for the same drug, and had a new, lucrative product, a product that cost considerably more than the same generic drug. Additionally, not all doctors make this clear when prescribing Sarafem. A number of women have told me that they had been prescribed Sarafem without knowing that it was, effectively, the SSRI antidepressant drug Prozac. But surely the FDA protects us against the abuse of profiteering pharmaceutical companies. They do have to review clinical trials that demonstrate a drug's effectiveness and safety. Unfortunately, the drug companies conduct multiple studies. They can cherry-pick the ones that they send to the FDA for review. One researcher, Dr. Irving Kirsch, an expert in placebo effects, was able to obtain the data from various SSRI trials, including the ones not submitted for FDA review. His findings indicated that SSRIs were no more effective in treating mild to moderate depression than a sugar pill, a placebo. This adds to the mounting evidence against antidepressant drugs. Antidepressant drugs affect neurotransmitter levels within hours or days, but mood elevation takes 2 more weeks. Why would this be? People with depression have normal levels of neurotransmitter release. When decreases in serotonin are artificially induced, it doesn't provoke feelings of depression. The various drugs seem equally effective, even though they work on different neurotransmitters. Some have suggested that antidepressants may work by increasing brain-derived neurotrophic factor, BDNF, and there's some evidence to support the increase in BDNF after antidepressant use. But not all antidepressants impact BDNF. For individuals with severe depression who do not respond to pharmacological treatments, other options must be explored. Electroconvulsive therapy is one such option. Though it's often portrayed as a barbaric, almost torture-like treatment, a relic of the past, it has been shown to be effective and is still used today. The basic approach, passing bursts of electrical current across the brain to stimulate convulsive seizures, has been refined over the decades. The length, timing, frequency and amplitude of ECT pulses has evolved, and sedatives and muscle relaxants are used to reduce the risk of injury. Memory loss, amnesia for events just prior to the ECT procedure, is still common, however. It's not clear how ECT may improve depression. In some ways, it's like having an old TV set with a bad picture and smacking it on the side to bring the wobbly image back into shape. It works, but it's not clear what you've done, and hopefully you're not making things worse in the long run. Repetitive transcranial magnetic stimulation is enjoying increasing popularity as a treatment option for depression. It's not as intense as ECT and can be done through a series of outpatient procedures. A number of centers are popping up to offer such treatment. But controlled research on this approach is still in its infancy. Some have suggested that it might work by causing changes in regional blood flow. However, it seems a bit premature to commit fully to this treatment option. Ongoing studies will help to validate its utility, and hopefully no long-term side effects will be identified. When these less invasive stimulation methods fail, deep brain stimulation may offer some hope. In this procedure, doctors implant electrodes deep into the brain to stimulate specific sites. A stimulator, a sort of pacemaker for the brain, is connected to these electrodes under the skin and implanted near to the collarbone. One area that's shown some promise for depression is stimulation of the subcallosal cingulate gyrus, otherwise known as Brodmann's area 25. What basic activities can we engage in to ward off depression? Some have recommended coffee as a protective factor, and there seems to be some research to suggest that moderate coffee consumption provides some benefit for depression. A number of studies also support the notion that exercise may help with depression. It seems both aerobic, e.g. running, and anaerobic, e.g. weight training, are effective, and that there's a dose-response relationship suggesting that more frequent exercise is better than infrequent exercise. Though it may be hard to get depressed people to initiate and maintain an exercise program, and while drug treatments may actually work faster than exercise programs in reducing depression, exercise is as effective as drugs in the long term and may actually result